Good evening, everyone, and first and foremost, let me thank Foxy for arranging this entire symposium. I think it's a beautiful concept to introduce the concept of obesity in women's health. I think obesity is something which is going to play a vital role in women's health in the coming years. We are already seeing an increasing number of women with PCOS, women with metabolic syndrome, women with obesity, and it's a very crucial part. So obesity is a crucial part of not only endocrinology management, but also a very crucial part of OBGYN as well, because women generally tend to the first point of contact is often their gynecologist and often their obstetricians, and that is a very important point of contact where the discussion on obesity should really start. Now, what I'm going to do is I'm going to, in the next 20 minutes, focus on pharmacotherapy and its role in obesity management, and that's where we are going to discuss. Before we understand, the pharmacotherapy in obesity management, we need to understand why we become obese in first place. So I think that is the important context to really begin with. Now, obesity generally starts before we are born, right? So it is genetic. There's a lot of component of obesity which is genetic, right? So we need to understand that there is a gene component as well, right? And as with evolution of time, I think the genetic component, we are trying to understand that in a better way. And then of course is the environment which is in the intrauterine period. Okay, now this is a very interesting concept, and I think a lot of gynecologists also should be taking interest in this. Since we are on the forum of Foxy, I think the intrauterine environment is a very important point of time where there are epigenetic changes which happen, and this epigenetic changes are ultimately what lead to obesity in future. Right now, there's a lot of work being done from India as well in this field. Dr. Yajnik, who has done a lot of work in this field. Now, the current prevailing theory, which is going on, is that we are in the intrauterine environment. Either there is maternal undernutrition or maternal overnutrition, and both of these can ultimately lead to epigenetic changes in the fetus, which predisposes the fetus to future obesity. Okay. And then we move on to the neonatal phase, right? And the neonatal phase, there is a theory that exposure to antibiotics early on in one's life leads to changes in the microbiome. Remember, there is a gut microbiome which is there, the gut microbiota, and this changes in the gut microbiota early in one's life can predispose the child to obesity. We all know that breastfeeding, and of course, again, we are on the Foxy forum, right? So breastfeeding protects the child against obesity. So introduction of formula feed early on, improper introduction of formula feed also can predispose the child to obesity. We all know a lot of these things, and a lot of these things are also undergoing a lot of research. And as the child grows older, the important stumbling block is the puberty, right? And you have, what we are seeing in terms of secular trend is that girls are having early puberty, right? So you have periods which are starting much earlier, right? Typically, the average age is 12.5 years, but we see often girls having puberty in their 10 or 11 years of age as well, right? So I think that's having menarche early. So I think there are a lot of pubertal changes also during puberty. Also, there is a lot of insulin resistance. We also see a lot of girls developing PCOS in the early adolescence phase as well. And then you go on to the phase of adulthood, right? And in adulthood, you have a lot of issues, right, in terms of psychological stress, social and economic issues also. These are all what contribute to a lot of issues at that point of time. And then of course you have medications which can contribute to obesity, right? So as the person grows older, the person is exposed to a lot of medications. For example, glucocorticoids can lead to obesity. Amongst anti-diabetic drugs, you have pioglitazone, which can lead to weight gain, sulfonylureas, which can lead to weight gain. There are certain antipsychotics which can cause weight gain. There are certain antidepressants which can cause weight gain. There are certain, you have antihistaminics very frequently used in abuse which can lead to weight gain, right? So these are all things which can lead to weight gain. And most important, of course, is the environmental factors, right? Improper sleep, lack of exercise, and obstructive sleep apnea. You have, the diet which is abnormal, right? So all these things ultimately lead to the chronic weight gain, right? Now remember, weight gain is a chronic disorder. I think what we need to understand is that it's a chronic disorder, right? It's something which has to be kind of looked at from a long-term perspective. Remember, there's a gradual weight gain, right? Very rarely do we see a person having sudden weight gain. Most of the time, the weight gain is gradual over a period of time, and that is what we need to kind of understand. We need to curtail, and we need to see this from a long perspective. You need to see this from an endocrinologist perspective, right? You need to see from a long-term perspective, and that is what is ultimately what leads to other thing, right? Now, one thing which is not shown in this slide and which is very important is the role of hormones, right? Endocrinology in this, right? And of course, whenever you have a person presenting to you with obesity, there are certain endocrine disorders, especially in women, that you need to rule out. You need to check the thyroid function, so look for hypothyroidism, right? Very important condition associated with weight gain. You have to look at PCOS. Remember, PCOS can lead to obesity. Obesity can lead to PCOS. So it's a vicious cycle, right? So that is what we look at. You need to look at other metabolic syndrome, right? You need to check for diabetes. You need to check for pre-diabetes. You need to check for dyslipidemia. You need to check for other metabolic parameters as well, right? So these are all associated conditions which are associated with obesity and which have an endocrine perspective. Cushing syndrome, though rare, right, is something you need to look for. We see a lot of women with iatrogenic Cushing, right? So that is exposure to steroids from outside, right? So iatrogenic or exogenous Cushing's is a very important condition that needs to be seen and that needs to be ruled out, right? So all these things ultimately lead to weight gain and ultimately lead to obesity, and we need to look at this in a broader context. Okay, now the very important organ, right? A lot of people say that what organ ultimately is linked with obesity. There are three organs which we really need to understand in terms of obesity. One is the brain, right? So brain is the most important organ associated with obesity. Second is the gut, right? And third is the endocrine system, right? So then you have all the organs associated with endocrine system. So these are the three organs which have strong link with obesity, right? So three systems which have strong link with obesity. So you have the central nervous system, you have the GI, and the endocrine system which are linked with obesity. And of these, I think the very important one and very well understood also is the brain, right? So when you talk about brain, now there are three different aspects of the brain that you need to understand. One is what is known as homeostatic eating. We'll discuss all of these three in a little detail. Second is what is known as hedonic eating, and third is what is known as the executive function, right? That is the ultimate control, the higher control that looks at this thing, right? So these are the three things which are associated with obesity, and these are the three things which we need to understand in terms of appetite and in terms of the brain functioning, role of the brain in obesity. Now, you have all heard of this term, that is the head hunger, right, and stomach hunger. Okay, so this is a very important concept that we need to understand even from a layman's perspective. Now, stomach hunger is when you are really hungry, right? You often say, people saying that पेट में चूहे दौड़ रहे हैं, right? That is basically stomach hunger. That is when you are really deprived of food and when you are really hungry, right? So a lot of people recognize this as a stomach hunger when you are really hungry. That is stomach hunger. But then there is another type of hunger, which is the hedonic part. This is the head hunger, right? So a lot of people, they are not really hungry, but there is a tendency to eat, right? Why there is a tendency to eat? Because apart from food serving the role of being nutritious, food also serves a role of giving pleasure, right? And that is the hedonic pathway, right? That is the pleasure that you get from food, right? Now, what happens is that one starts over a period of time using food to gain pleasure. That is what is the major cause of obesity worldwide. If you ask me one cause, I think that is the major reason, right? So if you're depressed, if you're tired, if you're happy, in all these conditions, you actually substitute other things with food, right? So we always see, let's say, look, I'm very happy, I got a promotion today. Let's go and celebrate with a cake, right? I'm having my birthday, let's have a cake, right? I'm not feeling well, I would like to eat something which I like, right? So we all start substituting a food as a form of reward, right? And that is where ultimately a lot of problems really arise, right? So homeostatic eating is definitely what is required for all of you. You require food to survive, but a lot of the time the food, this is the stomach hunger, right? But this is the head hunger, right? That is when you start substituting food as a form of reward, and that is what ultimately is a problem that needs to be curtailed. Okay. So talk about the hormones which are involved in the system. when you talk about homeostatic eating, right, there are two systems, one which produces satiety and the other system which produces hunger, right? So ghrelin is the hormone which increases the hunger. This, you have seen patients with, there are certain diseases where you tend to have resistance to ghrelin, right? And because of the resistance to ghrelin, you have these children becoming obese, right? So a typical example is Prader-Willi syndrome, right? So Prader-Willi syndrome is where you have resistance to ghrelin and you have typical weight gain which happens, right? So there is ghrelin, but the ghrelin does not act properly, and because of this, these children do not have satiety, right? On the other hand, you have the hormones which lead to satiety, where you have GLP-1, right, which is very important. You have peptide YY, which is also now being understood, leptin, insulin itself, and amylin. These are various hormones which lead to satiety, right? So this gives a signal to the brain that you have had enough food, now you don't need to eat further, right? And then you have the hedonic pathway, and hedonic pathway is where, like I said, you have the pleasure of eating, and this pleasure of eating is actually driven by two very important pathways. One is the dopamine and second is the opioid and the cannabinoid receptors, right? So basically, actually food is like having some sort of an opioid, right? The link of the food is the pleasure you get is the pleasure you get similar to opioid, right? So you have the cannabinoid pathway and the opioid pathway, which is also linked. So basically what happens is, it's like this, there's a system, there's a pathway which happens, right? So you eat, right, and there is a dopamine surge, right, and there is a cannabinoid, there's action on the cannabinoid receptor, right, and all of these ultimately lead to pleasure, right, and this pleasure then feeds back as a memory that you want to eat more, right? So that is the ultimate pathway. This is the hedonic pathway. Unfortunately, we are in an era, we are in the world of dopamine rush, right? We are looking for dopamine, we are looking for cannabinoid all the time, right? And in that sense, we are replacing all that with food. Social media also does a similar thing, right? If you have noticed, right? So that is how so eating is like being addicted to social media or addicted to gambling or addicted to any of such things, right? And then you have the third pathway, which is the executive function. Now this is where you take control, right? I say that I decide whether I want to eat or whether I don't want to eat. Now my body is saying there is a head hunger, there is a stomach hunger, and there is a head hunger, right? But I decide whether I want to eat or not, right? And this is the executive function. This is something which is self-regulatory. It is very difficult to obtain, very difficult to control, right? A lot of people, say a lot of things about it, but this is behavioral intervention, right? Are very difficult, but it can be done, right? So again, if you are very strong, if your executive function is very strong, that look, I'm going to eat only this much or I'm not going to eat, you are going to be well in control, right? Now, then comes the issue of how do you lose weight, right? So now we know why we gain weight, but now how do you lose weight? So any weight loss intervention strategy has this tick mark system, right? So initially you have weight loss and then you have the weight being regained, right? It is always like that, right? Any system you see, there is an initial weight loss and then there is a great weight gain which happens at a later period of time, right? So this is the system which is always seen in most of the system, right? So whether it is any type of intervention you see, this is true for every type of intervention, whether it is exercise, whether it is diet, whether it is yoga, whether it is pharmacotherapy, whether it is bariatric surgery. In all these conditions you have initial weight loss and then weight gain, right? So this type of system is always going to exist. Now why does this weight gain happen, right? This is a concept which is known as metabolic handicap, right? There is a metabolic handicap. Body always tries to go back to the original weight which it originally started with, right? So this is where it that is where it always try to go back, right? Somebody who is trying to gain weight also understands that the same problem happens when you're trying to gain weight also, right? If you're trying to gain weight also, the same metabolic handicap also comes in the picture. We really don't understand, to be very honest, why this metabolic handicap really happens and how we can overcome this. But what we do understand is this, right? This very important concept. And if you have to take one take-home concept today, I think you have to understand is that weight loss is not a ramp. It's not a ramp, right? You cannot lose weight like this. It is a step. It's a stepwise process, right? So initially you lose weight, then you maintain that weight, then you lose a little bit more weight, then you maintain that weight, you lose a little bit more weight and maintain that weight. Allow your body to get adapted to the new weight. If your body does not get adapted to the new weight, you will not, trust me, no matter what therapy you use, you will ultimately go back up again, right? So the idea is very important that you need to first lose a little bit of weight, maintain that weight, it is equally difficult, and then lose a little bit more and then maintain that weight more, right? And this typical, has to be over a 3 to 6 month cycle, right? So that every step has to be over a period of 3 to 6 months, a gradual weight loss process. That is only thing which will sustain you over a long period of time. If you try to rapidly lose weight, you will definitely regain the weight again, right? So that is why weight loss is very difficult. There are metabolic, hormonal changes and metabolic changes that happen as a result of weight loss, and this ultimately leads to weight regain, right? So that is something which you have to be very, very importantly cognizant of, and you need to understand this. So then, what are the options that we have in terms of weight loss, right? So you have lifestyle measures, which is medical nutrition therapy and physical therapy. We are not going to discuss that in too much detail. There are behavioral aspects of it. You can have behavioral modification, cognitive. This is the executive function, right? This is where you really take control of the system. Then you have pharmacotherapy, right? Pharmacotherapy is what we'll be discussing in more detail. And then pharmacotherapy typically leads to weight loss about 5 to 15%. And then you have surgical options, which can be, endoscopic, or, the other surgical options, which can ultimately lead to as much as 12 to 30% of weight, right? So these are all the options. Now what we're going to discuss is focus on the pharmacotherapy for weight loss, okay? So, what are the indications for pharmacotherapy for weight loss? So, if you see the Western guidelines, right, if you see Western guidelines, typically they say that, if your BMI is more than 30, or if your BMI is more than 25, plus you have complications, right, or you have some sort of a, comorbidities associated with weight gain. For example, you have metabolic syndrome, or you have, let's say you have diabetes, right? You have type 2 diabetes, or you have cardiovascular disease, right? All these conditions, again, these are the indications for considering pharmacotherapy. However, if you take in terms of Indian context, the Indian guidelines typically say is that if your BMI is more than 25, or if your BMI is more than 23 with comorbidities, you can be a candidate for pharmacotherapy, right? So you can consider pharmacotherapy in all these conditions. So if you have an obese diabetic patient with a BMI of 24, he's also a candidate for pharmacotherapy, right? From Indian perspective as well, right? So this is something we need to be well aware of, and this is where you need to really consider, right? Now, pharmacotherapy, modern pharmacotherapy can lead to as much as 15% of weight loss compared to placebo, right? So pharmacotherapy is effective. In fact, now pharmacotherapy is fast approaching the long-term weight loss which is seen with bariatric surgery also, right? So it is now becoming very close to bariatric surgery. In fact, the milder forms of bariatric surgery, like your sleeve gastrectomy, pharmacotherapy can now do as well, or in fact even better than sleeve gastrectomy, right? So I think that is something which we need to understand, that pharmacotherapy, in fact, a lot of bariatric surgeons always say that we do both, right? You can do sleeve also and do pharmacotherapy also, but which is a good argument. But in a long-term consideration, what you have to understand is that pharmacotherapy is going to be very, very effective, and it is getting better and better all the time. Now, what are the medical options for weight loss in terms of what is available in India? This is, like I said, the guideline from the West in terms of indication, but in India, your indication is actually lower. You can start pharmacotherapy at a lower weight also, right? Now, these are, you can see on the page, a lot of medications which are available for weight loss. So you have orlistat, you have phentermine, topiramate combination, you have naltrexone bupropion combination, you have liraglutide in a higher dose of 3 mg, you have semaglutide, and you have setmelanotide. Now, of these, in fact, a lot of these drugs are available in India, but they are not indicated for weight loss. In India, there are only 2 drugs which have been approved for weight loss or obesity as an indication. One is your, as you can see from here, one is your orlistat, another is semaglutide injectable 2.4 mg. Unfortunately, injectable semaglutide 2.4 mg is not available in India so far. What is available is oral semaglutide, which is in form of Rybelsus, right? Rybelsus is the oral semaglutide which is available. Oral semaglutide, they have not taken approval for weight loss. This is available in doses of 3, 7 and 14 mg. This is actually an anti-diabetic drug. But having said that, this off-label can be used for weight loss, because remember, in India, we already have approval for injectable semaglutide. The only thing is you don't have injectable available as yet, right? So off-label, you can consider using oral semaglutide, but it is being said that injectable semaglutide will be available as early as next year. It's a very popular drug throughout the world. You have a lot of celebrities. You have Elon Musk tweeting about it, right? So I think it's a very popular thing. The other drugs, including orlistat. We have used all of the other drugs in our practice before we had semaglutide available. Unfortunately, the results are not very good. The side effect profile is not great. Orlistat has been around for many years, and it's actually speaking a waste of money, because I've really, in my practice, not seen any patient really have significant weight loss, except for a few. Most patients do not have a good amount of weight loss with orlistat, right? So these are the aspects of this which you have to understand and you have to learn. Right now, why does semaglutide really produce weight loss? So why does GLP receptor agonist typically produce weight loss? Now here, I like to direct a very important thing, right? There is something called serendipity, right? You all know about the story of how antibiotics were first discovered, or how vaccination was discovered, right? This is all serendipity. In the same way, use of GLP in terms of as an anti-obesity drug is actually a serendipity, right? It's a chance event, right? Basically, these drugs were developed for diabetes management, right? But what was realized is that they also lead to significant amount of weight loss, right? That was what was seen right from the first earliest GLP that was available to now the most modern versions of GLP that are available. We have realized that this leads to weight loss. Now earlier it was not understood why this weight loss happens. So what was thought was there are two theories, which is this. One is the central mechanism, another is the peripheral mechanism, right? Now initially it was thought that this leads to slowing of gastric emptying, right? So gastric emptying becomes slow, right? And because gastric emptying becomes slow, you tend to have satiety, and because of that satiety you have people eating less, and because of that people have weight loss. That is what was the initial theory. But now it is known that it is probably not the only reason why people lose weight because of semaglutide. People probably have a central mechanism, right? And what is now understood is that there is a center called nucleus accumbens, and this is the center where you have, in the hypothalamic region, you have the center where you have the semaglutide or GLP-1 acting, and because of it acting over there, it tends to have, some direct action there that leads to satiety, and that leads to weight loss. And we already saw from that earlier slide that now it is well understood that there are GLP-1 receptors in the central nervous system also, which which ultimately are stimulated by these medications, and that lead to satiety, right? So there is actually reduction in the food seeking behavior, which is something which is not seen with a lot of other drugs in the past, and that is something which is very important, right? So a lot of these patients, we have now a lot of patients off label on oral semaglutide for weight loss, and what we realize is that the food seeking, the craving for the food literally goes away, right? And there is a lot of benefit as well. A lot of people say that now my obsession with food is gone, and now I'm able to concentrate on other things in life. For example, my work, for example, my family, right? There are my relationships. I'm able to concentrate on other things which are extremely effective in their life, right? So the craving for the food literally goes away. This food seeking behavior goes away, right? There are now extensive evidence for use of semaglutide for weight loss, right? You have now plenty of evidence. You have the entire series of step trials. So you have step 1, step 3, step 4, step 2. These are all trials which are done for specifically for weight loss. These are not diabetes trials. This is weight loss trials, and all of these trials showed significant weight loss. As you can see, throughout the spectrum, you had more than 2/3 of patients achieving 15% of weight loss, and a lot of these were actually women. Okay, so yeah. So looking at overall, so one condition where it is very important, and when you do a post hoc analysis specifically for PCOS and overweight women, right? In this group as well, it was found that semaglutide is very effective. In fact, now recently a friend of mine, has shown a paper where they looked at semaglutide, oral semaglutide 3 mg compared to metformin for PCOS, and found that oral semaglutide 3 mg is far more effective for the outcomes which is seen with this, right? Okay, so I'll not go into too much details of this, right? So I'm then come to important aspects. So you had, of course, liraglutide also 3 mg, which was, but unfortunately now liraglutide is being phased away by the original company as well. Now it's available as generic versions from other companies, but it's now being phased away by Novo Nordisk per se. But let me then come to an important aspect of this, right? So again, let me clarify here, right? Semaglutide, and because I'm going to anticipate a lot of questions which will come on this, so that's why let me first clarify. Semaglutide is available technically in 3 ways. One is oral, other is injectable for diabetes, right? And then you have injectable in form of for weight loss. Okay, so these are three forms in which is available. The oral one is called Rybelsus, right? The injectable one for diabetes is called Ozempic, and the injectable one for weight loss is called Wegovy, right? Wegovy, right? So these are the three forms in which is available. Currently, it is available in India only in oral form, which is called Rybelsus, which is only approved for diabetes management, but it is off-label use for weight loss, right? The Ozempic is not available in India, it's unlikely to be available in India. What we'll have in India is the injectable form for weight loss, which is called Wegovy, right? So this is going to be available in India next year, right? So right now, what we are using is an off-label, right? Off-label oral semaglutide for weight loss, which is in form of Rybelsus, right? And this is available in three strengths, like I said, 3, 7 and 14 milligram. We generally start at 3 milligram and gradually increase the dose up to 14 milligram. Now, you'll ask me how much weight loss have we seen? In our own practice, we have seen weight loss of 10 to 40, almost 15%, 10 to 15% weight loss that we have seen with the use of these agents in our clinical practice. So it's oral semaglutide off label. We have used it in non-diabetic patients also for weight loss purpose, and we found significant weight loss. The only side effect, of course, are GI side effects, right? And which are generally transient, right? So generally they last for about 2 to 3 weeks. Every time, either when you initiate the medication or you increase the dose, this is the side effect they will expect. The other side effect is the cost, I would say, right? Not a side effect, but you can say, it's a costly medication, cost about ultimately 10,000 rupees a month in terms of the expenditure. Having said that, a lot of patients are more than happy to spend that much if they are going to see good amount of weight loss, right? So that is the thing. There will be some percent, about 5%, who are resistant to this drug, in the sense that they do not have clinical efficacy, but most of the patients are doing very well with the use of this agent. Right. So ultimately, then there are a lot of other benefits. I'll leave it to the other talk also in terms of, and the panel discussion about these. So I'll not go into too much detail, but ultimately we know that there are a lot of studies which are shown with, not with SEMA right now, but with liraglutide, which have shown that there is improvement in the IVF pregnancy rate, there is improvement in PCOS outcome as well. So just to summarize, basically, the important point we have to understand is that weight loss is, weight gain is a gradual process. It happens over a period of time. It's a slow, gradual process. And pharmacotherapy has an important role to play in weight loss management. The only, I would say, the brightest future for this is the GLP-1 receptor agonist, right, or GLP analogs. GLP analogs, semaglutide is now the star in terms of the weight loss. It's very popular worldwide. In India, it is available in form of oral tablets, right? But in future, we'll have the injectable semaglutide also available soon, right? So I thank you for a patient listening.